glad to have you here with us today. I'm going to give it just one more minute to let everyone get settled. We'll be using the Q&A box today to ask questions, so feel free to do that and also upvote questions that you see there. And as you may have noticed and also heard in the announcement, the session is being recorded and will be available on YouTube tomorrow. Hey there, Victoria. Okay, it looks like the entrances are slowing down a bit, so let's go on and get started. My name is Ronise Zeman, and I am a bisexual 11-year survivor of stage 3B triple negative breast cancer. I was diagnosed at 38, just a few weeks before my twin boys turned 3. Fast forward now to 2021, I turned 50 in April. My wife and I celebrated our 28th anniversary at the beginning of the month, and our boys will be 15 in December. Wow. So today, YSC is excited to welcome Doctors Lori Wilson and Jason Domager to discuss A Time for Change, Addressing Disparities in Breast Cancer. This live stream will shed light on how certain populations within the YSC community experience unequal levels of care in their diagnosis, treatment, and provider interactions. We'll discuss current disparities for survivors and thrivers of color and individuals in the LGBTQ community, as well as the systemic issues to be addressed and how to advocate for change. Again, for any people who didn't hear me say earlier, use the chat to say hello, let us know where you're from. And then also the Q&A box is available for questions and for others to upvote questions so we know which ones are of high interest to respond to. Also, you'll receive a link to take the survey afterwards, so please participate in that so we know how this session was and how we can help you further in the future. For introductions, Dr. Lori Wilson is a cancer surgeon and researcher who is Chief of Surgical Oncology at Howard University Hospital and College of Medicine. And she works closely with multidisciplinary cancer teams to provide treatments individually tailored for each patient. She has been awarded for her teaching and speaks regularly about reducing health disparities. Jason Domager, MD, PhD, is a resident physician in the Department of Radiation Oncology at NYU. Jason's been engaged in several local and national initiatives aimed at improving medical students' education surrounding LGBTQ and sexual health topics. Welcome. Thank you both for your participation today. I look forward to us having a wonderful conversation and great Q&A afterward. Is there anything that either of you wanted to share with us as an open, or shall I jump right into questions?
Actually, there are a couple of things that I do want to add. Like yourself, I am actually a breast cancer survivor. I was diagnosed in 2012, initially with a stage 3 breast cancer, bilateral. So my breast cancer was found on both sides. In 2019, I was subsequently diagnosed with metastatic breast cancer. So I am thriving through a new diagnosis, but have been doing remarkably well, but have had greater experience that I'm glad to be able to share. From, one of the things that I also want to share, because living in the moment, knowing that when you have good news, when you have wonderful things to share, that there's no greater time than the present. And so I was actually promoted, or I am in the process of being promoted to full professor. I am one of 12 full professors in surgery in the country. And when we talk about disparities, that's a big disparity in itself, in that there is not as many academic Black female surgeons, and especially in the areas that we need. And so I just wanted to share how thankful I am for being asked to participate, but have a knowledge of going through this on a very personal level as well. Thank you.
Jason, anything to add before we get into questions?
Just another round of applause for Dr. Wilson. That is fantastic, and congratulations. I am very happy for you. And I just wanted to take also the opportunity just to thank Young Survivor Coalition to invite me to this really important topic, one that's really dear to my heart. And I really am very, very happy to be in this realm of working with patients who don't always have the voice to or the access to care that they truly deserve. And so I just really want to thank you again for allowing me the space to talk about what we're doing here too.
Wonderful. Well, that actually leads us right into our first question. At a high level, why do you think it's important to discuss the varying experiences of survivors and thrivers of color and the LGBTQ community?
I think that it is so important for us to be involved on every level, for us to get the best part of care, the best care that's out there. It's about knowledge, it's about discussion, it's about understanding. And I just think that the ongoing discussions that we have are so crucial to knowing where do we stand, what do we need to do to get the best possible care, and what is it that is needed for us to make sure that it's not only us who's getting the care if it's working well for us, but also how do we step into the role of being advocates for others? How do we become allies for others? And how do we make sure that we're making progress? And so that's kind of where I think we should be starting.
I completely echo that. And a lot of, I think what's going to be interesting as we talk about this is just the intersectionality of identity, and how just because you identify as one person doesn't mean you're, or one group doesn't mean you're excluded from the other. And those conversations really do cross lines. And that we also see that a lot of times various levels of identity can be compounders or confounders in terms of not having the same access. And like Dr. Wilson was saying, knowledge really is power. And so really getting a sense of where we are is really important. And a lot of disparities, we just don't have the information available to really say, where are we not doing well? How do we improve access to care? And how to really address some of the shortcomings that really impact so many patients? And so as we learn more, as we have more conversations, that's where we really can start getting a better, firmer understanding of where we are at and where some of our patients are not getting the same access to resources or care that they otherwise should be. And so how do we bridge those gaps and close them down?
Agreed. And once again, Dr. D, you've led us into our second question. So let's start with breast cancer screening and diagnosis. Where do you see the biggest gaps in detection and experience throughout diagnosis?
So speaking of in terms of the LGBT community, I think there's been a lot of conflicting evidence in terms of focusing on lesbian and bisexual women or cisgendered women in terms of whether or not there's differences in incidence in terms of breast cancer. And so there's a lot of mixed data on that. But one of the things that does come up is just the lack of the decreased access or the decreased use of mammograms and generalized breast cancer screening in these two groups. One of the bigger topics that really come up, and there's still just not data, and there's not a lot of really good recommendations, is breast cancer screening for those who identify as trans, whether that be trans men or trans women. There's still just lack of information available, and that's not just from the patient's point of view, but also providers as well. And so if you have a patient presenting to you who is a trans man or trans woman, like I was saying, a lot of times providers just don't know what are the recommended screenings. And I think having that shortcoming right out of the gate is tough, because then we're not really getting the people who may need screenings or potentially to address early forms of cancer really through the door in the first place. So I think that's a really big hurdle to overcome in terms of the LGBT or a sexual gender minority population.
Yes, exactly.
I think that also when we're looking at the populations that we serve, are we beginning with good tools of gathering data, of knowing who we're treating, and are our organizations catching up to identifying our patient populations in the way that they feel comfortable being identified? And is that data being then utilized in a substantive way in the organization? I think that many organizations are trying to catch up and trying to figure out, how do they do that, and how do they do that well? And how are we doing that from an ally standpoint, and how are we doing that from an advocacy standpoint? Because I'm not so sure we have enough allies and advocates out there that are helping organizations look in the direction that they should for gathering this data, because it really isn't about just the organization, it's about the community that we're serving. And when we think about this year, when we think about COVID, think about the disparities that we know we're going to be seeing in the future. We know that many of the communities that we serve just fell outside of the gathering of data about who is undergoing their screening studies, their screening for prevention, not only for breast, but across the board, for colon, for other areas as well. And so we want to make sure that we are gathering data and figuring out, how do we now go back and capture those groups? How do we make sure that they're actually going to now not lose out because they are being pushed a little later down a diagnosis trail, and then ultimately being found later on? And we know the implications of early diagnosis versus a later diagnosis.
Indeed. Can you explain why or how an individual of color or those who identify as LGBTQ+ may receive different care or access during their treatments?
Oh,
so many.
That goes down to a very personal level, right? We expect that we're all comfortably educated in that realm, that we as physicians understand what it is that our patients are looking for, how we're supposed to interact with them. And oftentimes it is about the initial impact that a learner may have, or interaction a learner may have with a particular educator. It doesn't mean that there's uniformity in the way that many of the discussions are held. I'd have to say, from a personal level, I've had different interactions, even being a physician. And those knowing that I'm a physician or not knowing that I'm a physician, I've been treated differently sometimes because of who I am and what the expectations are. I'm a big proponent for looking at patients from a cultural humility standpoint. Cultural competency is one of the underlying ways that we kind of sort of throw out there and say that from a cultural competency standpoint, if we are taught how to interact with people, that with facts, that we're going to be able to interact with them and know exactly what they may need. I'm a big proponent of cultural humility. Cultural humility is a little bit different. It says that we actually, as educators, have as much of a obligation to learn from our patients, and that our patients bring as much to the table about learning about who they are as we bring to the table about educating about their disease process. So if a patient sits down, I can't have this pious sort of thought that I am the only person in the room that has any knowledge about the process. That if I'm a good clinician, I'm listening to the person who's sitting across from me so that I can understand that they don't actually bring everything. Just because I'm a woman of color doesn't mean that I fit into every box that is expected to be of a woman of color. I come with a lot of different background, history, and so I'm hoping that we can disrupt the way that education has been taught, and that now we can say our patients bring equal amount of education about who they are. It's important for us to learn who they are when we are sitting down with them, to educate ourselves about who they are so that we can we can align ourselves with who they are and what they're trying to gather from their health standpoint. And then from then going on to really sharing the information that you have so that you can come in as a collaboration and not as this sort of, I know it all. And hopefully, if you come with that, then patients, I've had that actually happen to me with someone who did it so well that I was like, I just want to tell you everything. I want to tell you everything about me. You did such a good job listening to and hearing and echoing what I said. Let me just tell you everything. And it just gave me the opportunity to really kind of pour out who I am. And so like I said, I'm a big proponent of cultural humility, which is a little bit of a difference in the way that we're educating, and it's different from cultural competency.
And it makes such a vast difference. And I love the use of that term, cultural humility. You know what it is when you feel it and when you experience it, but
yes,
I hadn't had a phrase for it. So thanks, Dr. Wilson. Dr. D, do you have anything to add?
I think that's very well said. And I think it's kind of echoing that is being able to be a provider that gives the patient the space to be who they are. So allowing our patients to be able to be their authentic selves and meet them at where they're coming from, and knowing that, and very much like Dr. Wilson was saying, knowing that we don't know everything. We may know a lot about a disease, but we don't know a lot about the person. The person knows themselves more than we could ever know themselves. And so I think it's really important that when we engage with a cancer diagnosis, we take a step back and realize that this is a small facet of the person. Like there's so much more to them and so many other things that they're coming in with. And it's important to provide that space to best care for our patients, to tailor treatments, to tailor the conversation, to really acknowledge that this process is not just impacting them, it's impacting their chosen family, it's impacting their community, it's impacting so many aspects of their life, that it's important that we have those dialogues and we're not neglecting those components, because if we're truly to provide care, it's important that we provide care for the whole person. And I think that's really where the conversation really needs to start and continue. And it's an ongoing conversation. And so I feel that a lot of times in the healthcare situation, we're presented with like, this is the one-liner of the patient. And a lot of it is just the biology of the disease. And that really just there's so much missing in that component. And a lot of times we don't provide the space for patients to give that information of who they are as a person, who's helping them through this process, and who is important individuals in their life. And a lot of times people are just going through this in an invisible kind of component where they feel that they can't be their authentic selves through this process. And that's just a disservice, in my opinion.
Agreed completely. My goodness.
That was so well said. I am so it's so much in agreement to being able to bring that authentic relationship to the person that you're turning your life over to, in these intimate moments, that you're giving them this opportunity to really care for you in a way that few people in your life you allow to do that.
So we've talked about the experience that people have throughout diagnosis and treatment. Can health disparities continue throughout to survivorship? And where do you see this come up the most?
So I think absolutely, unfortunately, and absolutely. So a lot of times after one's been through this tremendous journey, and whatever that journey is and continues to be for those people, there's so much components of physical health, emotional health, psychological health that still need to be continued and still have those conversations. So I know a lot of patients now are given survivorship plans, and what that typically means is, or just continued plans is continued appointments, continued like other cancer screenings that they're going through, other just general upkeep and checkpoints. And for the LGBTQ community, a lot of times there's a lot of components there that are not properly addressed. And so I had a lot of patients who their chosen family would like to be going to support groups, and a lot of times they're not accessible to them, or the support groups that are available really don't reflect what they're looking for. They feel welcome there. So for example, if there is a patient who is a cisgendered woman in who's lesbian identified and married to another woman or partner with another woman, or a lot of times too, we'll have patients coming in with ex-partners that are really good support systems, that those partners and chosen family really want to and deserve to have opportunities to kind of debrief and have that continued care, but they're being placed into support groups that aren't really reflective of their experiences, their identities. And so these prolonged care and survivorship things are not truly reflective and not really encompassing or inclusive. And so I think there's still, and just to kind of circumnavigate the question, but yeah, I do think there's unfortunately a lot of disparities that still reside, that still need a lot of addressing.
Yeah, I think in survivorship, there's this expectation of normalcy, or you're moving into this normal phase again, and your life honestly is never the same. You have these triggers that you may not have had before, and now you're noticing them. You have these differences in the ways that you relate to people, the ways that your relationships sort of evolve. And oftentimes, if you share the experience with others about having a diagnosis of breast cancer, it can almost be overwhelming sometimes to share some of those experiences as you're moving along in survivorship. It was very difficult for me when I was re-diagnosed with my metastatic diagnosis 2 years ago, of what now did that mean for me, because no one's diagnosis is the same. You don't know what your journey is going to be now. You had this, this pattern in your life where I'm on my medications, I'm doing what I'm supposed to be doing, and I'm following up with my appointments. And now I have this new thing that's happening in my life. So what does that mean? Does that mean a difference in my time frame? Does it mean a difference in my health? Does it mean a difference in the way that I'm going to be able to live my life? And should I now be changing the structure of what my life should be? So there's a lot of things that happen in this sort of transition to survivorship. It's very unique and is very dynamic. And I'm not sure it's well addressed with just endpoints of, see your doctor every 3 months, or see your doctor every 6 months, or, what we want for you is if something happens, just let us know. And that is just so much. And I just want to put that out there. That is so much pressure for one person to have to self-diagnose if something's actually going on. So I'm supposed to figure out that, and I do this for a living. And so everything I'm like, okay, is that something? Okay, is that something? Is that something? And I don't think that clinicians understand the level of pressure that goes along with survivorship. And when something may happen, how quickly something is found is left in the lap of the patient.
Right. That definitely is a hardship, especially when you don't have anything set up for routine MRI every year. Having that expectation as a triple negative patient, I don't take anything, no hormone blockers or such. And my oncologist doesn't believe in having regular scans. So, right. Yes, I have lots of, oh my God, well, is that a thing? And you know, we make our way through it, right?
And so, I'm not sure we make our way through it or we talk our way through it. Do we do it because we have to do it, but right. There's got to be a better way. And that's why research is so important. And that's why having ongoing, being part of clinical trials, being a part of all these things are so important, because the simple things of just having a diagnostic tool for survivorship isn't really available for us, for most. And it is really dependent on your clinician who's following you to gather you and take you through the next steps of what your life is going to be.
Yeah. I've had a lot of patients too from a radiation oncology perspective. And so, as some of you may have experienced personally, is during the radiation treatments, there's a very regimented schedule that occurs every day for a prolonged period of time. And towards the end of that, I've seen it with talking to my patients, just that anxiety of like, all of a sudden you're like, what do you mean I'm done? And like, I'm left to my own, like
and even months seems like too long. I have patients who, in the practice that I have for myself, who want to see me every month. They just, it seems as though after seeing someone who's very supportive and caring and seeing them every day, and then all of a sudden you're not going to see them, those are things that survivorship, I think we need to begin to deal with and sort of understand. How do we best serve our patients in the next transition?
Yes, absolutely.
So that leads very well into the next set of questions. What would be your advice to individuals on how best to communicate their individual needs or concerns with their healthcare team? And what if they're interacting with a provider who does not understand their culture or their lifestyle?
I find that probably one of the most difficult things, because we know that healthcare providers may be limited to some areas of the country. Mm-hmm. And so if you have the opportunity to sort of shop around and find that person that is your compadre who, speaks and hears you and listens to you and is that person, then that's wonderful. If you do not feel heard, if you don't feel as though you're being handled in the way that is caring and compassionate and understanding, then you absolutely should have the comfort and the option to move to an additional practice. But we know that that's not always the option. And so reaching out to support systems within the healthcare providers network. There should be patient navigators. There should be patient advocates for you. There can always be someone who can be paired with you from a organization that is near you, and may even be, now that we have the ability to do Zoom and to do virtual, to have someone who can really talk you through how do you do it if you're feeling that way, because those opportunities are definitely there for you. And having someone who has the experience and then the exposure of how do you do it, because I know it's frightening. It's frightening actually saying to your physician, hey, I don't feel like you're listening to me. I don't feel like this is working for me. Is there anything else that we can do? That's probably one of the most scary things that you can do or say. And so
we don't feel empowered to be able to do that, to be able to say that.
Yeah, and I'm hoping that we all know there are organizations out there that are advocates. There are organizations out there and within hopefully the same network that also can provide that support that you need, so that you can have someone there with you, or someone to talk to through you, to help you say what you want to say in a way that the clinician can hear you.
Exactly.
Absolutely.
Maybe anything to add?
100% too. And I think, as many people have experienced, is the cancer treatments are multidisciplinary. And so finding, even if it's not in the care or the treatments that you're receiving, if you identify a physician that really helps and listens, but there's another that's not, really going back to the ones that you trust in for referrals and communication components. One of the things we tend to see, unfortunately, in the LGBTQ community is the fear that if I do come out to my provider, are they going to withhold, deny, or provide substandard care because of this information? And your people's lives are in the line with a cancer diagnosis, and that's some fear that people are just not willing to gamble with. And again, as Dr. Wilson was saying, we don't always have the privilege of having a lot of different providers at our disposal, depending upon where one lives. So you may be in a situation where you're in a smaller community and there's not a lot of providers around, and you're kind of stuck in a situation. So I think extending outside of the institution too is also great, to have different resources, advocates, different grassroots organizations that can provide guidance and support, or different people just to go through the journey with you. I think the conversation is really important. So, and the question really coming back to it is under making sure that the needs are being addressed. And I think having that, establishing that relationship early on and having that open dialogue as one goes through this process and saying, you know, right now, these are the needs I require, but that may change, and checking in is really important to identify which needs are coming up, which concerns are coming up, and just trying to foster that relationship, but also acknowledge that if it's not working, it's not working. It's not your fault if it's not working. A lot of times our providers are not equipped to handle the information, either through lack of training or whatever baggage they bring with them. And that's not your fault if it's not clicking. And it's okay to look for other providers too, to make sure that all of your needs are being addressed. And if it's not in the same institution, it's okay. If you need additional assistance elsewhere, it's okay as well. But I think it's just important to note that if it's not working, it's not your fault, that there's a multitude of different reasons, and that communication is always very important.
For sure. So what would be your advice to healthcare providers to be more inclusive in their communication and care?
I think providing a space to have those dialogues, and being okay with whatever that dialogue turns into, and however that patient feels. Unfortunately, a lot of times in medical training, we're not always taught how, a lot of it's very factual based, a lot of if this, then that, and dealing with people, it's not something that's as emphasized, unfortunately, as much as it really should be. And so a lot of doctors come into it well-intended, but just not equipped. So if we're asked, okay, I'm going to ask about who are you sexually attracted to? And if this is the information, and like we're trained to ask these questions, but we're not always trained to say like, okay, what does that necessarily mean? How does this come into play in terms of your care? How does this come into play in terms of what different sexual side effects may be important, what other components of your care are important. And so having these dialogue, and a lot of it's going to be coming from training. So improving our training, and then also just improving how to engage with patients and understanding that it's okay for providers to say, like, I don't know what that means. I don't know what to do with that. I'm sorry if I say things wrong, but it's okay. But I'm willing to be here and learn from this to make sure that I provide the care for you for this. And so sometimes our patients may have to be a little bit of our guides, which should not always be the case, but sometimes it ends up being that. But as long as the providers are open and willing to go through that journey with you and learn from that, I think it's a path that a lot of us are having to take.
Yes, that willingness is highly important. Dr. Wilson, did you have anything to add?
I just can't reinforce that enough, that having the opportunity to understand that you're not, as a clinician, you may not always be perfect. That's a difficult place to be for many physicians. I think that our systems are built on accuracy. Our systems are built on high scoring, on knowing lots of information, and may not be as emphatic about the care and the relationship building aspect with patients. I think that one of the things that I have sort of relearned and retaught myself is going into the room each and every time. I have to look at it as a learning experience, that when I come out of a room, how did I do that well, or did I not do that well? What could I have done differently with that patient that I think could have made that interaction better? And if you do that each and every time, then you're posturing yourself and putting yourself in the perfect place to learn, and not to be so set in, was it a right or wrong, but was it what the patient needed? And then I think the other thing that I try to do now is realize that the discussion is more, for me, a check-in. So I don't start with all of so what brings you here today, and so tell me about when did you have your last period, or all of these. I want to know, so tell me how you're doing. What is the most concerning thing that's going on with you right now? And really sort of getting into more of a discussion about where the patient is. Because if the patient isn't in a space that they feel that they can share with you because they had the worst argument of their life, or their partner has decided that they no longer want to be in a relationship, or one of these many different things, then I'm never going to get to that very authentic place, because in their heart of hearts, they're sitting there thinking about my life, what's going on, and how horrible or how great things are. And so giving people the opportunity to share in the moment, and to give the opportunity to really begin to just check in with who they are and what's going on. And then ultimately shaping that conversation into, well, now that we kind of know where you are, we can deal with the major things that are going on in here and now. Then I can gather information. I can gather information at any time. It doesn't have to be in this, very routine way. But knowing who I'm dealing with and what that person needs at the moment is probably the most important thing for me. And I think that was a reprogramming that I had to do early in my career.
Yeah. So how do you think disparities impact co-survivors or caregivers during their loved ones' treatment and survivorship?
think that's a really interesting question. And so I think throughout the cancer journeys, I saw this happen with when my dad was diagnosed with lung cancer, and my mom went from being his partner to the caregiver, and that seeing that relationship change and then how it morphed into wearing different hats was very interesting and very insightful for me. Unfortunately, he did end up passing from his disease, but for those who don't, I think renegotiating or refiguring out where those relationships change and where things lie at the various parts of this process is very important. And like I was saying very early on, it's important for us to not neglect or overlook the spouse or providers or whoever the patient has chosen to bring with them throughout this process. And so these people, these individuals, these groups, these communities also need care, and they also need spaces to be heard, spaces to heal, spaces to recover. And so I think a lot of times we first off, regardless who you are, I don't think we provide spaces for the spouse and the support system for patients very well. And I think that needs to be addressed first. And then also creating spaces that people feel safe for and included and welcome to is a very important part. And so it was very difficult that I noticed also during COVID. We continued to treat during COVID, but the problem was we restricted how many people could come to appointments. And so
if anyone could come,
nobody was coming besides the patient. And so that is so traumatic. It was so traumatic that people were coming down with treatments, dealing with side effects, even hearing a diagnosis for the first time, or those conversations. So much of it gets lost just because of the shock of the initial conversations. And so not having a sounding board that can also weigh in or catch some of it, or be that person, that documentarian person, is just, there was so much lost with that and so many different components to it. But I do think that we really need to put more emphasis on caring again for the entire group, the entire community that's dealing with this diagnosis, and creating a space every step of the way that the person can feel welcomed, included, and heard is an important component.
I'd have to agree. I can look through the lens of being a mom, the lens of being a wife, the lens of being, a sister, an aunt, and all of these people, family and friends. I always say friends are family that you choose for yourself. And all of these people wanting to care for you and wanting to be there for you and not being able to share in that experience. It was very difficult for my husband, especially early on when I got my metastatic diagnosis, because it was, we were just getting into COVID when we were trying to make decisions about treatment and care and what we're going to do. And those are big decisions to make about what is are you going to do a clinical trial? Are you going to go into treatment that is a standard treatment? Do you know what that's going to mean? Are we going to go from one income, go from two incomes to one income? For us, we're a two-income family. And even though I'm a physician and I'm speaking from a real point of view, we need both of our incomes because we have 3 children. We have a life that goes on, and healthcare can be expensive. And so I felt that there were definitely times that it left my husband out of the discussion, that there wasn't enough support for him, and that it was sometimes heartbreaking for me because you love the people in your lives, and not being able to share as much of the experience with them as you can, and then them not having the ability to share in the way that they had or that they felt that they should with other family members. So it was definitely difficult.
Do you have any ideas about how individuals can advocate for their own equal treatment and how allies could help to advocate?
There's some really great organizations out there. There are great systems built into the multidisciplinary approach to medicine. I think Dr. D put it really very well that it's a team approach. We no longer treat cancer as a single physician. And so if there is that one person that you really clicked with, they're oftentimes more than happy to share and to help in that experience. But I want to make sure that everyone explores what are the opportunities within their own organization or within their own community for what is available. You know, is there an organization like YSC that or is there are there other organizations that are specifically tailored to what your needs are? I am lucky to be in an organization that 95% of my population that I serve is Black. And so I'm ethnically available for my patients. The vast majority of them are female. And I hope that I am beginning to listen enough to begin to understand if their needs aren't met, that there are others that can potentially do that for them, and to make sure that we're opening up that to others in the structures, such as patient navigators, nurse navigators, patient advocates, allies within the organization, and allies in the bigger picture. There's so much research and so much resource building in breast cancer, and the way that we support breast cancer survivors, that I think that there's a place for many. It's just utilizing the resource in a way that is effective for ourselves.
100% agree. Yeah. And so one of the things very similar to is one of the things we try to do is and advocate for is to not necessarily like tunnel vision that you only can look in this one little space, but branch out for those who are accessible. So one of the things we're trying to do at NYU is also build champions. So champions in different departments that are go-to people who can really serve as an advocate and really just help direct individuals. A lot of times being a cisgendered gay man, I'm one of the token gays in our department. And so whenever there's a patient who needs some assistance, I'm pulled in, and I always give the caveat, like, I don't live every lived experience. And so I may not be equipped to help, but at least I can help direct and provide a listening ear that's open and welcoming. And so really trying to provide those resources to provide that open space that is able to then direct and connect, I think is a really important thing, because like Dr. Wilson was also saying too, we're not going to be able to be the poster child for every lived experience, we can try to be that person that people can go to, or form different relationships that people can go to find those that will best serve them, or provide those resources or those advocates or the allyship that they may need for those processes. I do think a lot of times, especially within the LGBTQ community, a lot of times the ownership of disclosing falls upon the patient's shoulder. Mm-hmm. And it can be challenging, can be very challenging, because who do I come out to? Who's going to be welcoming? If I tell the nurse, will the nurse be welcoming? If I tell the therapist, will the therapist be working? If I have a name that's different than my legal name, is that going to show up on my wristband? Are the phlebotomist going to have an issue? Or there's so many different levels, because you interact with so many different people at so many different times. And so navigating that system can be very complex and challenging. And so having somebody you can link back to, that anchor person, is always very important. And also creating structures and institutions where you don't have to worry about those complexities, where you say, am I going to be included or have the opportunity to participate in a clinical trial? Is it going to be offered to me? Is it something I'll be welcomed into? There's so much complexity to it. And so I think creating spaces and creating like an environmental survey of where are we doing well, where are we not doing well, for various identities and through different lenses, is going to be very important to take some of that ownership off of patients to then I'm not happy to decide, is this a safe space for me or not?
I love that you said that, because that hits on our final question, which which asks about systemic change. Dr. Wilson, I didn't mean to cut you off, so go on and continue.
No, I think the only thing that I was going to add to that is I love the fact that you talk about having champions and how important it is for us in those organizations to bring diversity and to expand the knowledge pool by really advocating to the C-suite or those that are in charge to bring others to the organization to help to teach and to educate at every possible opportunity. Can we make sure that we have as much opportunity to learn and to have those discussions, those open discussions for people to really begin to explore what all of this means to them, even though they may not have learned it when they were in school. Now they're expected to practice it. And that can't always be easy. But if we as champions begin to do that, I think that that's important as well.
Wonderful. We have had such a great discussion. I really appreciate everything that you have had to say and the time that you've shared with us today. I see now that we are very close to the end of our time.
So quick.
Very. There are some questions that we have from our attendees. I'm hoping we can get in a few of them. Again, we are talking about a time for change, addressing disparities in breast cancer. We've been talking with Dr. Lori Wilson, a cancer surgeon and researcher, chief surgical oncology at Howard University Hospital and College of Medicine, and also Jason Domager. He's a resident physician in the Department of Radiation Oncology at NYU. So the first question that I'll ask is, are there efforts to make clinical trials more diverse? I've heard the participants aren't usually very diverse and inclusive.
So that's an accurate statement. We know that when we look at diversity within our community and diversity in clinical trials, that they don't match. For instance, Black Americans are about 13% of the population. Only about 5% of participants in clinical trials are actually Black. And so there is a tremendous amount of work that we need to do. But I think that our voices are being heard, that there are definitely pushes by major organizations like NIH and major organizations who do this funding to make sure that they begin to hear it. But there's so much work to be done. We're nowhere near where we need to be.
100% agree. And in terms of LGBT components too, is we just don't know. The data is not collected. A lot of the major databases that we have for cancer registries don't even include sexual orientation, gender identity. So we don't have outcome measures to say, is there any outcome differences between these individuals in these communities? So some efforts have been undertaken to try to change how the information that's asked on entry into clinical trials to make sure that the opportunities to disclose or be fully identified is available. It's something we're trying to do at NYU as well, to make sure that there's opportunities to self-disclose whatever information or any identity that makes sense to you is available, that you don't feel that you're being placed into boxes. But this is an ongoing effort that becomes very challenging just because sometimes clinical trials are also extending multiple countries. And so having those components addressed in a global sense can be very challenging as well.
And so always using your voice, in every opportunity. If you have the opportunity to fill out a questionnaire remember, clinical trials aren't always about being a participant in a treatment. It may be just getting ideas about what your thoughts are. So being involved in as much about your clinical data as possible, as you're comfortable with, all has purpose.
Yes. Well, and right along with that, using your voice, if I feel like I was discriminated against by my doctor, what can I do?
So that is not an easy question to answer, but there are always within organizations, there are always those advocates who are meant to address those. And so they're patient advocates within the organization, they're patient representatives within the organization, they're patient I'm sorry, I'm blanking on, I'm having a chemo brain moment. And so there are definitely those who are tagged in the organization to deal with that. If you're feeling as though you're discriminated against, don't feel as though that you have to hold that information, that you have no other option. You always have options. You should always be respected as a patient, and you should always be cared for in a way that is respectful and is in line with who you are and how you want to be treated.
I have one more, I think, important question to ask. Are there trainings for surgical oncologists on how to talk to women about breasts in ways that are thoughtful and sensitive? My breasts are part of my body and not my identity, and the language my current doc uses is offensive.
So there oftentimes are not ongoing detailed educational experiences for surgical oncologists. And yes, you're absolutely right. I had a bilateral mastectomy. I lost my reconstruction to infection, and decided that when my husband and I, we decided together that I was not going to be reconstructed. So I don't wear any of the prosthetics or anything like that, but it is often connected somehow with who I am as a person. And I am much more than that. You know, I have decided that, you know, I can be a great person without having breast. And sometimes your clinicians don't even understand that that was offensive. And so trying to have that discussion, if it's possible, if you feel that the clinician is open to that. And if not, reaching out to the advocate within the organization to let them know that there is a need for educational understanding for patients' emotional needs, and educating those how to discuss, because oftentimes organizations don't know they need to do it unless you use your voice and you point it out.
Exactly. Well, thank you, Drs. Wilson and Domagauer, for taking your time today to serve as our expert panelists. Attendees, if you are interested in other YSC programs and support, please visit youngsurvival.org. And if you missed out on last month's YSC Summit, there is still time to register and watch all of the great content on demand. So you can go to summit.young